Hi, everyone. Welcome to today's discussion on navigating insurance denials. My name is Jenna Mbalo, and I'm the Director of Patient Advocacy and Community Engagement at the MGFA, and I'll be moderating today's session. It's my pleasure to introduce today's speakers. First, we have Dr. Charlene Hafer-Macco. She is an Associate Professor of Neurology at the University of Maryland and was named MGFA's 2008 Doctor of the Year. Dr. Macco is an Associate Professor of Neurology at the Maryland School of Medicine and is the Medical Director of the Myasthenia Gravis Center at the University of Maryland Medical Center. She serves as the co-director of the Neuromuscular Fellowship and the director of the Baltimore Veterans Administration Medical Center of Neuromuscular Service. She also is an honorary and former MGFA board member. Welcome.
Thank you.
Next we have Michelle Vogel. Michelle is the VP of Patient Advocacy and Provider Relations at CSI Pharmacy. She works in patient advocacy, and it is her passion to help patients navigate the healthcare system. Welcome. And finally, we are joined by Anna Reid. She is a patient advocacy volunteer with the MGFA. Diagnosed with MG as a teen in 1990, Anna is based in Nashville, where she is a writer. She has published several essays based on her personal experiences with chronic disease. Anna is passionate about traveling and has visited over 30 countries. Welcome, Anna.
Thank you.
And I've had the privilege of serving with all three of these presenters on the MGFA Advocacy Work Group, and I'm very excited for them to give today's presentation. With that, I'll hand it over to you guys.
Great. Well, I will start with just discussing the insurance process. Although we're going to spend most of the time talking about the approval and denial system and trying to prevent denials, it's important for us to know about making sure your insurance goes through. So when you have a claim, the first thing we're going to do is verify your benefits. And then the next thing, either, your provider's office will investigate the coverage criteria for your insurance. And then we'll begin a prior authorization process. And hopefully you won't go to a denial, but if you do, it'll be either approval or denial of claim. Next slide. So prior authorization is one of the most important processes of the insurance process. It can be called prior authorization, pre-certification, but it's an extra step that most insurance companies require before they decide if they're going to pay for expensive specialists, procedures, and specialty therapies. During the process, the insurer may request and review medical records, your test results, and other information so they can make an informed decision. The insurer will determine if the service is deemed medically necessary and identified as a covered service under your insurance policy based on what information is submitted. Usually your doctor or pharmacist is notified in writing or by phone, and you will receive a letter. If you are denied, you can appeal, and I'm going to say you must appeal, and that's the importance of this discussion today. You will most likely win your appeal, but the insurance company is banking on you not appealing, so you have to go through the process. If you are told you do not need a prior authorization, make sure this is true. 99% of the time, you're going to need that prior authorization, and if you don't get it and it's not covered, the benefit, then you're going to be responsible for the cost of the claim. Next slide. Charlene?
So the first step in really trying to secure one of your medications or therapies that you're trying to get is to know your insurance guidelines. And this is really criteria for seeing the specialist, for getting DME, for getting all your medications, not just the infusion therapies. And so the first step is really making sure your diagnosis is coded correctly. And for myasthenia, we have myasthenia, which is G70.00, and then we also have one that it denotes an acute exacerbation or refractory MG, which has a simple 1 substituted. And sometimes that is sort of in your chart in multiple ways and may get sort of the non-emergency or non-refractory coded in what's submitted. So these are some of the things we're going to troubleshoot on the denial part. But what is an acute exacerbation? So that's a crisis. And then for those who are having refractory myasthenia, what does that mean? Well, it means even though you're on excellent therapy, you may be on Mestinon, you may be on steroids, you may be on a steroid-sparing drug like Celsep or Imuran. Even despite those good therapies, you still are having myasthenic symptoms. And so at that point, you're considered that you may have failed therapy. And for many of these insurance companies, they want you to fail 2 of those. So it's nice with IVIG. They do count steroids in that some of them are making sure that you need failed two steroid-sparing drugs, or even recommending you get Rituxan, which, we want to follow our guidelines for the MG treatment strategies. Many times, it needs to be a neurologist that's prescribing and not simply your family doctor or your primary care. And then who should submit that bill and this pre-op process? Well, if you're getting it in an infusion center, it may be your neurologist. If you're getting it at home, it will be a specialty pharmacist who will work with your neurologist to secure the medical records and, as Michelle said, the supporting data. So is myasthenia confirmed? And how did they make that diagnosis? And then that information gets submitted. All patients for these very expensive therapies really always need a prior auth. So as she said, if they say no, let's question that and just go that extra step. For the subcutaneous, that'll be a different process. It won't be just the medication, and securing the infusion nurse. This time it will be securing the medication, a nurse to help teach you how to administer it, and then troubleshoot it through your course, and then getting the therapy. As we say at the bottom, and you may or may not be able to see that at the bottom of the screen, many times you need the literature to support the use of that in your particular situation. So that gives the evidence to the reviewing physician, who may or may not be a neurologist. Next. So it's not just about the IVIG and the subcutaneous immunoglobulin. We have now other therapies that we may be able to use. And one of the medications is the complement inhibitors. And so the criteria they're asking for these medications is that you're acetylcholine receptor positive. And this is important because the immunoglobulins in the acetylcholine receptor actually bind complement, and I'm sure you're going to be hearing through the national conference, actually activate complement to do some of the destruction at the neuromuscular junction. And so these are approved for that. The MuSK positive actually has a different subset of immunoglobulins that don't fix complement, so are not appropriate. They require the MGFA classification be criteria 2 through 4. So what are those? Very quickly, 1 is ocular only. So we're not using it for ocular symptoms. 2 through 4 are mild, moderate, and severe symptoms. And then we have with or without the breathing and swallowing difficulties. And then the MGADL scale is a scale of 8 symptoms of myasthenia. And so these are, do you have double vision, ptosis, troubles chewing, swallowing, and it goes through all of them. You need a score greater than 6. Now, here's where things get tricky. For these medications, many of them are, because of their expense, are requiring that you be on at least 2 steroid-sparing medications. And many of these take months to even out to a year to know it's fully effective. So there's a big delay with therapy. So these, you can see them listed. And with at least with the Solaris, they do not count steroids or prednisone as your immunosuppressive therapy. Then their next step is to require that you've failed chronic IVIG or ongoing plasmapheresis, and many of them say you need to use Rituxan as well. So in this prior auth, to sort of avert that appeal, having your physician state why you meet these criteria by different means, or why Rituxan may or may not be appropriate for you, are very important. So next, Michelle.
So Medicare is often complicated in terms of where you're covered for your therapies. So Part A is hospital inpatient, but it's also if you're considered homebound, and you can get certain therapies done in the home under Part A. Part B is your infusion center, your physician infusion suite, your hospital outpatient infusion centers. Part D is your drug benefit, and that's where your home infusion comes into play. And many patients ask the question, can I afford to get these therapies under Part D? And especially IVIG is one of them that we get the question all the time. And I say yes. And I understand the question. It's because of that donut hole. And people say, I can't afford it. Well, many of the specialty pharmacies offer financial assistance programs. You have to just ask. And most of you will be eligible for some kind of assistance, if not all 100% assistance from the companies. And there's many of these companies, and there's lots of competition for you.
So same question with Solaris and Zilucoplan. The question is asked, can it be done in the home? So the criteria I face with many of the insurance companies is they really are looking for documentation if you're going to get it in the home that you are homebound. That means you're not a community navigator. You're not going out to the store to get your medications. You're not shopping. You really are limited in your room-to-room mobility. Now, that has changed a bit with the COVID pandemic because now we really want to keep our individuals who are on immunosuppression not out in public. As Chip said, follow the 3 W's. I like that in acronym. But we want to, so if you're homebound, they will, as Michelle said, maybe consider doing it there. Zilucoplan is a subcutaneous, so you have to administer that in at home. And so then, Michelle, can you choose the company you want to use?
So the answer is yes under Medicare, which is great. There's what's called any willing provider laws, which allow patients to choose which provider they go with. And so if a patient gets a letter from an insurance company saying that you have to switch your specialty pharmacies to another company, under Medicare, that's against the law. Under private insurance, they're allowed to do that. And under a federal employees health benefit program, they're allowed to do that. And so this gets really confusing for the patient, especially if they've been with a nurse for many years. And so you can try to see if that nurse can go with you to the new company. But this is something that we're all trying to fight.
And then there are many fewer providers, and so there's actually there are plans for the complement inhibitors. So,
next slide. For assistance programs, for immunoglobulin therapy, it's very expensive. And so many patients, especially if you're in a private insurance plan, have high deductible plans or major copays or coinsurance. So a lot of patients ask, do any of the manufacturers have assistance programs for me? Well, there are a few companies that do not specify a disease. And that's Pfizer for the brand Panzica, which is an IV form of immunoglobulin, and Cutiquick, which is a subcutaneous form. And then BPL has an assistance program for Gamaplex, which is an IV form. For Medicare patients, you cannot get a manufacturer to give you assistance. But again, for any patient, you can ask your specialty pharmacy, your home infusion company, if they have assistance programs. And don't forget to ask the infusion centers. I've heard of many infusion centers who have assistance programs, and they all have payment plans. Next slide.
and the same is true for our complement inhibitors. There is the assistance fund was helping cover many of the copays. During the COVID pandemic, they helped out an awful lot, and the fund became used up a bit, but they have a waiting list, and so they're still taking in new clients, and as the fund gets replenished, we'll be able to offer assistance again, I am told. And then when the assistance fund had troubles helping with copays, then the National Organization of Rare Diseases actually stepped up and was able to help with assistance for a number of my patients, and that was just a month or two ago. Could I have the next slide?
All right, I'll jump in here. And just a reminder, you can ask questions in the chat. We'll have some time at the end for questions. So we'd love to hear what's on your mind and try to help you out the best that we can. So to talk a little bit about the appeals process, as a MG patient for over 30 years, I totally understand how frustrating dealing with insurance companies can be, especially when you get a denial. We're trying to navigate our symptoms and our health, and it can be so frustrating. So we've put together some tips for you if you do get denied. The first thing is, as Michelle said earlier, don't take a denial as a no. Unfortunately, a lot of times for us, it's just part of the process that we have to go through in order to get the result that we need, as frustrating as it might be. So don't take the denial as a no. Appeal. Don't panic, be prepared, and be aware of your rights. So go ahead and take me to the next slide, please. All right, so the first tip we have is just to get organized. Insurance information can be really overwhelming. There's some great resources that the foundation has, and the advocacy work group that we're all a part of is working to make those even better. So definitely check in on the website if you haven't already. Make sure that you identify the time that you have to appeal. It's very important because it is going to be limited. So just be aware of that as you start the process. And then review carefully your health insurance plan and your coverage, and understand why you were denied. And if you don't understand why you were denied, then reach out to your doctor's office or to the foundation to try to help you understand that. It's going to be very important as you move through the process. You can request a free copy of your insurance standards and records if you need those. A lot of the times those are accessible online. You might already have them, but make sure that you read them and know what you're dealing with as you move forward. Have a system for tracking all of your notes, your records, your correspondence with your insurance company. You want to keep as detailed notes as you possibly can, and maybe even note how you're feeling and what your symptoms are as you're going through the process. That might come in handy for you later. So go ahead and take us to the next slide, please. Thank you. All right, so again, you want to review the insurance plan, make sure it's the plan that was in place at the time of the denial, which may or may not be your current plan. Read the entire plan, not just the summary. And a lot of larger companies and even some smaller companies now have benefits departments that might be able to help you if your insurance is through an employer. All right, next slide. Great. Okay, so just a couple of things important. What does your plan say about your right to appeal? Look for your deadlines for filing and where to send your appeal. You want to make sure that you do get that right the first time so you don't have any sort of issues meeting the deadline if you've sent your information to the wrong place. And Michelle is going to talk just a little bit about what your options are if your appeal is unsuccessful.
Great. Next slide. So what happens when your treatment's denied? You need to understand why it was denied. So if it's that the insurer considered it not medically necessary, which happens often because a lot of these therapies aren't FDA approved, we want to make sure, did the provider put all the evidence that you needed to support the use for your medical condition? And so did you fail the therapies that you need to fail? Did you have the testing to show that you have Meister Gravis? And so you need to understand all of those things. Was it coded properly? Was it coded not as chronic MG, but as acute MG or refractory MG? And what are the coverage criteria being applied to your denial? So you need to understand what that denial actually says so that you can address it.
So, Michelle, I often find that just knowing what the insurance company are looking for. And so when we're treating refractory, the question is what are the criteria that really are they looking for a clinical indication? And one of them is trouble breathing. One is trouble swallowing, and then sort of leg weakness that may lead to falls, because these are things that are going to take you in the hospital and they're going to have to deal on the back end. So what I think is important is, we were talking before, Michelle said a lot of times you go to your doctor and you're fine, you're fine, you're fine. Well, they need to know when you're not fine because they really need this information to justify the treatments. So if you're short of breath, what activities in your daily living are making you short of breath? Now, we all know going up the stairs could make you short of breath, but if simply bending over, tying your shoes, or makes you winded, or while you're seated talking, you can't catch your breath, you need a little more therapy. Are you having trouble choking? Have you changed your diet? Are you having trouble maintaining weight because of the difficulties chewing and swallowing? This is important information. And even though you feel fine because you want to keep a positive outlook and really do your best with this disease, I think it's good to check in with family members who have been watching and sort of get their input before your visit and say, have you noticed anything about my swallowing? Is my breathing truly okay? What are you seeing? And that way the information is valid.
And keeping a diary of your symptoms, because sometimes we get foggy and we can't remember what's going on. And so if we keep, a journal and, when was it difficult? I was having problems swallowing and, at lunch or dinner or between meals or drinking water, those things, or, your breathing issues, you notice weakness. When was it? How often? So those things so that you can quantify it for your doctor. Because I know too many times we go in and the doctor says, how are you feeling? And you're like, okay. You need to complain. You need to really tell the doctor what's going on. The doctor can't read your mind. Next slide. So this is probably one of the most complicated slides here, the appeals process, and understanding the different kinds of appeals, because each insurance company has a different process. So you have to understand what your insurance company's process is. Some insurance companies will give an option to do a peer-to-peer before you have to do a formal appeal. And that's where the doctor talks to hopefully another doctor, but it may not be. It may be a pharmacist. It may be someone that has nothing to do with neurology that would understand your disease. And most likely it won't be another neurologist. Other times you have to submit a formal appeal. And then if you're denied that formal appeal, then it goes to the peer-to-peer. The external review, you have to really think about this, because when you get to that point, that's the last resort. And it's usually with the insurance commissioner. It's outside of your whole insurance company. And once you do that, if you lose, there won't be another opportunity to start a new prior authorization till the next plan year. And then an urgent appeal, it depends on your insurance, if it's within 24, 48, 72 hours. And Charlene, you had some suggestions or concerns about urgent appeals for myasthenia gravis patients.
Yeah, because if we need an answer in 24 to 72 hours, this is the point where my patients are considering going in to the emergency room really to get treated. So then it changes from trying to get outpatient therapies to really doing what they need to get inpatient, because you don't want to put off a myasthenic emergency awaiting for this appeal process. Next slide.
All right, so we're just going to cover a couple of things about writing a successful appeal letter. So you can typically find your insurance company's phone number and mailing address on the back of your insurance cards, or on your explanation of benefits, also called your EOB, or on the denial letter from your insurance company. Make sure that you include your name if you're the patient, or the patient's name, the policy number, and the policy holder's name. Be sure to include contact information as well as the detailed notes about why you think the charges were denied in error. And again, this goes back to understanding that from the beginning of why you were denied, so you can fight that. And be sure to cite the terms of the insurance policy that apply to your particular situation. It does help sometimes to tell your own story, but definitely stick to the facts. And then if you are going to put a personal appeal, just keep it brief. And Michelle might be able to offer some tips on some situations where it might be possible to keep to put in some personal information. Michelle, do you have anything to throw in here?
Sure. So for patients who maybe want to go to, say, a subcutaneous product and your insurance will only cover IV. We've had people who have jobs that they just can't take the time to have IV infusions, the number of hours. And so telling the kind of job you have, or the type of reactions you've had from your own personal, history of how many times you had to go to the hospital for a reaction, or like with COVID, just the concerns of leaving the home and wanting to have it done in the home. So those are all important things that, you bring that personal story in. But again, you don't want to make it a lot of pages. You want to keep it to a few paragraphs and get to the point.
Well, and I actually have had some patients switching to sub-Q, like when they've had Mediport infections. And so, or there are maybe like a woman who had an infection in her heart. We really didn't want to put a central line in, so that she needed to go to subcutaneous at that point. And like you were saying, it may be occupational. There may be like infectious exposures that we really don't want the IV or the port exposed to. It may be time to go to sub-Q.
All right, we'll take it to the next slide, please. Okay, so this is where all those notes that you've been taking throughout the process are going to come in handy. If you can make photocopies of supporting documents and basically backing up your claim, and make sure that you provide the date on the denial letter or EOB of what charges were denied and the provider who was supposed to be paid if you know why the charges were denied. Again, we're going to keep detailed notes, receipts, correspondence, all of your interactions, even after you send off the appeal letter. And make sure that you follow those guidelines that your insurance company has laid out in supporting and making the appeal. That way you don't lose any precious time as you're going through this process. So lastly, we say be a pest. It's a process, and we know it can be frustrating, but be as patient as you can be. Again, don't panic and be persistent. If you haven't heard back within about 2 weeks or the time frame that you've been given on your EOB, then make sure that your materials have been received in their system. You can call and just check on the status. And we're here for you. So if you go on to the next slide, please. This is a slide with our information. So take a minute and jot that down if you think we can be of any help to you. And as a patient, I'm happy to give anybody any support that I can. I know it's a long and overwhelming process at times, and I know Michelle and Charlene are here to help as well. And again, I'll just mention that the advocacy work group is preparing some documents, and there's already some information on the foundation's website that might be helpful to you about this process, as well as about many other things. So if you haven't had a chance to take a look at that and you're interested, please do. So we'll pass it back over to Jenna.
Thanks, Anna. Thanks, everyone. So we've got some questions we're going to tackle next. Okay, so the first one is from a support group leader that has members that need financial assistance. Any suggestions?
So it depends on what type of financial assistance. You know, if it's for certain medication, it depends on what side of care they're in. So if they're in the home care setting, ask the specialty pharmacy if they have any kind of assistance programs internally to help them. Same thing with an infusion center. Ask them if they have any programs. If yours doesn't, then shop around, because there will be somebody who can help. Some of the manufacturers have assistance programs, and then you have the Assistance Fund and NORD that have programs. So there are programs out there, and it just depends on what exactly you need help with.
And so I'd actually like to extend this beyond our infusions. Many folks are even having troubles affording medications like the azathioprine, the Cellcept. Prednisone's fairly cheap, so that one is okay. It's the side effects of that one. But there are some options like GoodRx. If your neurologist has a social worker with you, who works in the clinic, they may help find other alternatives for coverage for some of the other medications, because many of them are very expensive. I had a patient on Meister time span, and somehow this year her medications went up to $1,500, and it's like, this is unusual. And we looked, and even through GoodRx, it was very high. So finding workarounds for many of these medications are important.
And some of their some of those manufacturers may have assistance programs. So I Google a lot. I spend a lot of time Googling. There are some programs through different organizations for equipment. So there are things out there. You can definitely email me, and I will see what I can do to try to put you in the right direction.
And at that same kind of light, even some of your other medications for your diabetes, hypertension, look for assistance with those, with their manufacturers as well, because you're not on one many people aren't on one medication, they're on several, and they add up, those copays.
Mm-hmm.
One tip I have that may not be applicable to everyone, but I typically, if I've met my deductible, and because I have health insurance, then at the end of the year, if it's possible for me to go in and order medication at the very end of December, then I can get my script filled and hopefully not have to pay for it soon, because I don't know if the formulary is going to change. So I typically look at the benefit of have I met my deductible, and what am I paying, and is it reasonable before we get into the next calendar year?
And that's actually important, because that next calendar year is when many of these policies change, even for like the immunoglobulin. And so the insurance companies are thinking about whether they want to cover again for the next calendar year.
That's great. Thanks for all the suggestions, everyone. And just what was previously mentioned before, too, is there is that resources page on the MGFA website that has links to some of the recommendations that were just referenced. So the next question is, with the link provider.
We actually lost Jenna. So with any willing providers law, does that apply to Medicare Advantage or traditional Medicare?
All of it. So both Medicare Advantage and regular traditional Medicare, you have the right to choose which providers. Now, granted, Medicare Advantage plans, depending upon what you have, they can have, if it's an HMO or PPO, they may have a certain network that you go through. So it could be more limited, but there is a lot of flexibility. Under traditional Medicare Part D, you can choose whichever provider you want. And for doctors, as long as they participate in Medicare, that gives you a lot of choices.
Thanks. How is homebound defined? And if I'm not considered homebound but have secondary private insurance, could I still get Solaris home infusions?
The folks at Solaris and Alexion are very good at reviewing the insurance and looking at your benefits, just like many of the specialty pharmacists, to really understand how you're going to have the best coverage. And sometimes, even though it may be preferred or not preferred to do it in the home versus an infusion center, the medications are expensive, and getting them covered, I sometimes find it's hard if I don't meet that homebound to get it in at the home, but other patients have been able to get it. So I think it's really insurance company dependent.
Yeah, if it's private insurance, you will most likely have flexibility between your infusion center and home infusion. However, the number of home infusion companies providing Solaris may be limited. And so you have to look and see if that provider has the product for you. In terms of if it's Medicare, I have only done patients through Medicare Part D, but I know working with Alexion that they have patients who are under Medicare Part A getting covered for Solaris. So I haven't had that experience.
And for the infusion, for many of these medications, there is specialty nursing training for the infusions, and you really want a nurse who is experienced in each of these products, who can monitor you for your side effects, really understand the indications, and just has the expertise needed with the criteria through the infusion programs.
Thank you. Okay, this next question is, as a 43-year-old, how do I get Medicare coverage?
So as a 43-year-old, you would have to be considered disabled in order to get Medicare. So you have to go through the disability process, and for disability, the date you apply for disability, it's 2 years after that date when that you would be eligible for Medicare. And so, and the disability process is not a fun process to go through. So, but, you know, there are many patients who are on disability. So if that's the question, I mean, there's no other way that I can see getting Medicare without disability at that age.
Thanks, Michelle.
You're correct, yeah.
Okay, this next question is, I have completed a phase 3 trial for Zilucoplan. I'm now in an open label enrollment. Raw Pharma is supposedly applying for FDA approval. Has Zilucoplan already been approved per the slides?
Not yet, but it's like, you know, we're in preparation for, for hoping for that to be approved. But I'm sure you're going to go through the exact same criteria, and they haven't been defined yet on what we're going to need, what hoops to jump through. But it's right around the corner. Fingers crossed.
Right. Thanks. Okay, are negative CTs for thymectomy cause for denial? What can we do to prevent that type of denial? And what if you have two doctors that are in conflict over the course of treatment?
So I'll take that one. In terms of having chest CT that shows thymus tissue for making the diagnosis, I have not seen insurance companies denying medications or infusion therapies based on the presence or absence of thymic tissue expansion. Now, I don't know if the person is asking, will they cover the thymectomy? And so, you know, you have two doctors in conflict. I think, you know, what you really want to do is make sure that you've seen a neuromuscular specialist in myasthenia gravis to really help guide that course for the thymectomy.
Okay, this next question is, who should do your appeal? I have to do my own due to time issues, and it's not getting done by a doctor's office.
So depending upon what the appeal is for, and so if it's for a medication, and the medication's being done in a specialty pharmacy, then, or home infusion, then the specialty pharmacy really should be working on the appeal. If it's something for a procedure or medication done in an infusion center, the neurologist usually takes the lead on it. I can tell you from my own experience, recently I did my own appeal on something that, you know, was through a provider that just wasn't covered, and the insurance wasn't covering it, and I couldn't really get anywhere, so I need to submit it myself. And you just need to pull all the documentation together. But, you know, somebody should be working on it, and it shouldn't just be left to you, but I know personally it happens.
Thanks. In 2020, I had home infusions of IVIG approved by my good private insurer, GEHA. I have Medicare A and B, but not D. Medicaid denied my home infusions in 2020. Currently in 2021 and beyond, will Medicare B cover home infusions for IVIG?
So you can get your IVIG under Medicare Part B in the infusion center. I'm not sure why. I mean, if you're continuing to have Medicare and Medicaid, then we have to look at and see why the Medicaid didn't cover it. And so you're usually a dual eligible, and we can work on seeing how that's supposed to work because they should have the prescription plan. And so I'm more than happy for you to get in contact with me so I can look at what's happening with you and see how we can get that resolved.
Thank you, Michelle. This next one is, with the hope of new treatment coming soon, do the insurance companies tend to deny these treatments when they first come out?
I would say they don't, but I think it's the experience that we learn to sort of learn the language of what they're looking for. What do you think, Michelle?
So,
each process is different.
Just different. However, when it's FDA approved for your indication, it's an exciting time. And so it's been a while, and we're finally starting to get therapies approved for myasthenia gravis. And so the insurance company can't say it's medically not necessary based on your diagnosis. If you meet the criteria, it usually will be covered, but be prepared for step therapy. They're going to want you to fail on all the cheap therapies before they're going to want to spend a lot of money on the expensive therapies. But I would say that we're going to see more and more of these therapies covered.
And I would agree. It is such an exciting time. And, there are so many new therapeutics coming out in the landscape. And just to sort of plug our exhibitors and our sponsors, this is an exciting time to have them partner with us and to really, for us to understand how to make sure our clients and with MG really get access to these therapies, these new therapies.
Mm-hmm. Agreed.
I certainly remember back in 1990 how few treatments there were and how much has happened over the last 3 decades has been unbelievable. So.
An exciting time indeed. We're going to go over to one last question, which is, how often are patients an active part of the appeals process?
So it depends.
Yeah.
Go ahead, it depends. It depends. So, the patient should automatically be notified that the treatment was denied and that you're going to have to appeal it. And regardless of what site of care, what it is, the provider should be in contact with you. In a perfect world, the provider's doing the bulk of the work and submitting it. However, it's your appeal. It's your denial, and you need to make sure things are getting submitted in time. So just like we say, appeal, 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 be a pest on every level and make sure everything is getting submitted on time. And so you want to see movement and nobody's sitting on anything. And so you want to just have that point person at wherever it is, your doctor's office, at the specialty pharmacy who you can work with, and be checking on a daily basis, if need be, to make sure it was submitted. When do you expect to find out that there's going to be a determination? And see that and ask for copies of things.
And I would second that. You had the most at stake. This is your disease, and so really making sure it goes through. I actually, before we sign off, as part of the working group for advocacy, I would love if you've had successful appeal letters from your physician, from your specialty pharmacist. Ask if they could share those with us and redact your name and your personal information. And then if you have appealed, we would love to include those in the toolkit, to help others who are struggling like you.
Thanks, Charlene. And I know that we referenced it a little bit, but maybe you guys would mind just taking a minute, just speaking a little bit more about this upcoming toolkit and what it's going to have and what kinds of resources will be there for people to utilize.
Anna, do you want to?
Yeah, a lot of what we've covered in today's presentation will be in there. We're also going to have just some generic advice through that is kind of filtered down through the MG community and other patients with successful appeals along the lines of what Charlene was just asking for. So we'd love to have your story, if it's a successful one, or even if it hasn't been successful, we'd like to know what hasn't worked as well. So we will have all of the financial assistance information that we've talked about, plus some other that we've gathered from the community. And there's also going to be some information from kind of the legal side of things that'll be really generic that might help you go through the process as well. So I've spent the last few weeks talking to a lot of people in the MG community about specific experiences. So as I compile that, I'll kind of see what patterns emerge, and we'll have that posted, I would say, within the next month or so. And it also might be good if we can take the slide back to our contact information, just in case anybody needs to jot that down. I think it was there we go. So that's how you can get in touch with any of us.
Thanks, Anna. And before we wrap things up, I'd like to just ask each one of the speakers if you want to leave us with any final thoughts that you have.
I like Michelle's appeal.
Definitely. I would say also the newest trend I see in denials is not denying the therapy, but potentially denying the dose, and making sure you're getting the right dose for your disease. And so know that if that happens, there is a way to resolve that. And don't take too low of a dose as the answer. So I'm more than happy to take any questions that you want to email to me. I promise to get back in touch with you, but keep fighting because you will win.
Great. Thanks, Michelle. Well, I want to thank everybody for attending this session. I want to give a special thank you to our speakers. Thank you, Michelle, Charlene, and Anna, for your time and your insights and all of your wisdom in this area. It's really appreciated. So thanks so much.